Good day to everyone joining us, and welcome to today's X-Talks webinar. Today's talk is entitled, Implementing a Comprehensive Meningitis Encephalitis Diagnostic Test in a Community Hospital. My name is Candace, and I'll be your X-Talks host for today. Today's webinar will run for approximately 60 minutes. This presentation includes a Q&A session with our speakers. This webinar is designed to be interactive, and webinars work best when you're involved. So please feel free to submit questions and comments for our speakers throughout the presentation using the questions chat box, and we'll try to attend to your questions during the Q&A session. This chat box is located in the control panel on the right-hand side of your screen. If you require any assistance, please contact me at any time by sending a message using this chat panel. At this time, all participants are in listen-only mode. Please note that this event will be recorded and made available for streaming on xtalks.com. At this point, I'd like to thank BioFire, who developed the content for this presentation. With more than 25 years of molecular experience, BioFire Diagnostics sets the standard for molecular diagnostics through its pioneering advances in syndromic infectious disease testing. The syndromic approach is a symptom-driven diagnostic method that combines a broad grouping of probable pathogenic causes into a single rapid test. This allows physicians to easily choose the right test the first time. Their innovative team leads the industry in infectious disease diagnostics and provides molecular solutions that lessen the time to medical results, empower healthcare professionals to make better diagnostic decisions, and lower healthcare costs. They are committed to improving the quality of life for everyone, everywhere, every day. Now I'd like to introduce our speakers for today's event. Dr. Javed Siddiqui is a co-founder and chief medical officer for Telemed2U, a 100% telemedicine-based multi-specialty clinical practice. Dr. Siddiqui has been actively involved in telemedicine since 2002 and has been recognized as a national thought leader in the field. Dr. Siddiqui served as the medical director of one of the nation's top telemedicine programs at the University of California, Davis. In addition to being an infectious diseases physician, Dr. Siddiqui is a recognized medical technologist who has previously held an appointment at the School of Engineering, University of California, Berkeley, and served as the first medical director of California's Institute for Science and Innovation, the Center for Information Technology Research in the Interest of Society. Dr. Siddiqui has lectured throughout the United States and internationally on telemedicine and serves as an advisor and board member to a number of telemedicine and healthcare technology companies. Our next speaker is Arpad Peter, who is the Director of Laboratories at Adventist Health Howard Memorial. Mr. Peter has over 30 years of experience working in a community hospital setting and over a decade of experience working in a clinical laboratory. He obtained his Bachelor of Science in Medical Technology at Loma Linda University. Before I hand this presentation over to our speakers, I'd like to launch a poll of questions for our audience members to participate in. And that poll question will be launching now. And this poll question reads, how familiar are you with the BioFire Meningitis Encephalitis panel? Audience members, please vote from the following options. Really familiar? We understand the details of the panel, but we need more information. We have heard about this, but really do not know the details. Or, this is the first time that we are hearing of this panel. Audience members, please participate in this poll right now by clicking on the options appearing on your screen. Once again, that poll question is, how familiar are you with the BioFire Meningitis Encephalitis panel? Now it looks like a majority of our audience members have voted. I'm going to close the poll and share the results with you now. And it looks like the most popular answer is really familiar at 45%, followed by we understand the details of the panel, but we need more information at 34%, followed by a tie between we have heard about this, but really do not know the details, and first time that we are hearing of this panel. Audience members, thank you very much for participating in this poll. Now, without further ado, I'd like to hand the mic and the presentation over to our speakers, who may begin when they're ready.
Good morning. My name is Dr. Javed Siddiqui. Thank you so much for taking the time to join this presentation today. I'm truly honored to be with my colleague, Arpad Peter, who really look forward to engaging in this conversation with you all. So with further ado, Arpad, do you mind getting started and telling everyone a little bit about Frank R. Howard Hospital, where we work and what we do?
Absolutely. Howard Hospital is a small, critical access, community-based hospital in Willis, California. We do a pretty good general amount of medicine in the hospital. We have a med-surg unit. We have a very heavy ortho surgery department for a hospital our size. We probably do about 170 surgeries a month, and most of them are ortho. Our various departments are just what you would find in a normal hospital. Our clinical laboratory, on the other hand, is exceptional. We basically have a wide variety of services, which you can see there, and support or open basically every day of the year, at least some. So our really crown jewel, so to speak, is microbiology. And we'll be talking more about that as we move on.
Absolutely. So Arpad, you know, that leads into exactly my experience. So when I first came to Frank R. Howard Hospital, and I was touring the hospital and thinking about joining on as the infectious disease clinician there, one of the things that really struck me was the lab that you've created there. Really an outstanding state-of-the-art laboratory in this critical access hospital. So can you tell me a little bit about the lab's philosophy and how you were able to achieve this?
It really is driven from the whole culture of the hospital itself and the community. Very strong support from our community through a foundation, very strong support from our physicians in general. And so as a laboratory, our struggle has been to survive, like most of us out there in the industry. We need to survive and stay relevant to care that can be provided right on site. And so we've had tremendous support, both from our foundation, our physicians, and from the laboratory itself and our staff. Our desire is to be a place of excellence and nothing less.
So Arpad, so tell me, the support that you've gotten from the hospital leadership, how is, you know, people focus on, hey, we're a 25-bed critical access hospital. Why should we have this degree of laboratory support? How have you answered that question, and how has the hospital leadership responded to that?
You know, that's a great question. It's very easy. It's simply being the desire to provide really excellent care that's meaningful on site. So to a patient, that means results as quickly as possible, because time is life, time is pain, so on and so forth. Time is of the essence when we're out here, basically out in the sticks. Our execs interact with the physicians, and the execs have had a very high desire to make our physicians as satisfied as possible in being able to take care of our patients. And so when we've actually maintained good upward communication with our bosses here at the hospital and letting them know what opportunities we have to serve our physicians and our patients better.
You know, I couldn't agree with you more. I think one of the things sometimes people miss out on the fact is that when you're a community-based hospital or a critical access hospital, you know, there isn't the world's greatest medical center down the road, right? And it takes hours in order to transport patients there, and a tremendous amount of resources. And to be able to answer those questions, those clinical questions, right there when we need it, that really serves the patient that you're taking care of and the community so well, and really credit you for having that philosophy. So with that said, let's move on to your experience with PCR. So tell me, when did you first learn about multiplex PCR, and where was your first encounter regarding this type of technology?
Well over 10 years ago. Again, our struggle to be relevant and meaningful and needed in our hospital as a laboratory. You know, we attended several educational symposiums and presentations. And one of them was right here in California, about 3-4 hours away. And we ran into something called Cepheid, which is a PCR platform. It's not necessarily multiplex, especially at that time, but MRSA testing was out there. And we came back from that. We learned as much as we could. We came back, and then we talked to our docs. Is this something that you need? How would this help you? And so for our ortho guys, they want to know if the patient's colonized before they take them to surgery. And so that's pretty common almost in every hospital. And so these questions, and so we were the first in our health system to have a PCR platform in their hospital. That machine is still in our laboratory today, and we're very proud of it. So, but moving on, what it did is it exposed us. It exposed us to the benefits of rapid, specific, and very sensitive testing that we never had before. The game was changing. We didn't realize how much then we did realize that how important, and now we take it for granted.
So, you said something there that I think is so crucial. And being a clinical infectious disease physician, this is a rarity, and unfortunately, it's a rarity. You said you came back and you spoke to the providers, right? Let's talk about that a little bit more. Why do you think so many laboratories have a hesitation of speaking to their providers and asking them, what do you need? Because in my own personal experience is before coming to Frank R. Howard Hospital, I always had to reach out to the lab. I always had to engage conversation. It was very rare that the laboratory director or someone from microbiology would pick up the phone and call me. Yeah, they may call me about a specific result. Hey, got a weird susceptibility testing on a patient. But just, hey, I saw this. Is this something that you're going to utilize? Tell me why you're so comfortable in doing that and how that came about for you.
It has to do with our culture. It has to do with, like, say, our desire to stay on the edge, our desire to stay relevant, because we can become unrelevant very quickly. And a small hospital is a small hospital, but that is not the mold that we want it to be in. And so we basically created our own mold. And that is to strive to be the best small hospital laboratory in the world. So, it kind of sounds a little haughty, but it's not. Anyone can do it.
That's fabulous. So here's that Cepheid that you had talked about. So tell me, how do you then go from Cepheid, MRSA testing, a very specific one test, to then thinking about BioFire? How do you move? How do you make that leap of faith there? And when did you first get exposed to the whole idea of BioFire multiplex PCR?
At that point, it becomes as easy as falling off a log, because it does. Once you realize and get a taste, you want more. And once the physicians realize what they have and get a taste, it is very easy. At that point, it almost becomes a demand. All you have to do is let them know what their options are. Our first introduction to BioFire was where? At a symposium, at a presentation. And so we found out, and at that point, I think there was only two or three panels available on BioFire. And as soon as we found out, we immediately ordered our first unit because we realized what was going to happen. We came back to the hospital and let our physicians know, did you know you can get this now? We could do this for you. We can get all these targets for you, not just MRSA, not just Staph aureus, not just C. diff, not just some of the other things, but we could get all these things for you in one panel. Now, ED gets very interested, because ED is those guys really want to know a lot of stuff real quick. And that right now, if you were to let me give you an example. If we were to try to take our multiplex PCR platform out of our hospital, there would be revolt. Well, it is not going to be accepted. It is just not. Yeah.
You're absolutely correct. I didn't mean to interrupt you, but you're absolutely correct. Being a clinician practicing at that hospital, I'm probably going to lead that revolt. So you're absolutely correct on that one.
Okay.
So again, here's that BioFire system and the multiplex PCRs we were talking about. So again, you continually say you engage the providers and you ask them what they wanted. And I think that is such an important tool and something that we need to do a lot more of, that connection between laboratory and clinical services. So if it's okay with you, let's change topics a little bit. So let me tell everyone who's joined us this morning and this afternoon a little bit about the infectious disease consultative services at Frank R. Howard. So as Arpad mentioned, Frank R. Howard, we're a 25-bed critical access hospital. So obviously right now there is a paucity of access to infectious disease services across the United States. So one of the unique things that we do is we're 100% telemedicine-based infectious disease consultative service, right? So I live almost 300 miles from Frank R. Howard Hospital. My office is almost 300 miles from there. And so it's a telemedicine-based service. I'm there multiple times during the day. After we finish our conversation here a little later on, I got a couple of patients to round on. So that's what we do. We do all the services that an infectious disease physician would provide. We developed and implemented an antimicrobial stewardship program, and we also provide medical leadership for infection prevention. All right. So let me tell you a little bit about the history. So I started working at Frank R. Howard, and almost on my first day, Arpad contacted me and said, and matter of fact, it was really, as we were preparing for this presentation, I was thinking about this. The first time I visited Howard Hospital, and Arpad was giving me a tour of the laboratory, there were the boxes for BioFire. He hadn't unpacked them yet, and I just looked at it, I read the label, and I remember looking at Arpad going, seriously? You have multiplex PCR? And he said, of course we do. And by the time we get you credentialed and get you going, this will be up and running. I mean, it was just amazing for me to coming from an academic medical center to working at Frank R. Howard to now know I'm going to have the sophistication and the level of multiplex PCR and rapid diagnostics and pathogen identification. So it was incredible, and I know, and really it helped solidify my decision. I want to work at Frank R. Howard Hospital because I knew that the commitment was there from the laboratory for this type of technology. So what we did was, as we were setting up, as Arpad and the group were setting up everything, we had conversations as to what should be our initial panel. And one of the things we talked about was the meningitis encephalitis panel, because we really wanted to look at what is the clinical impact going to be, right? And one of the things, as Arpad mentioned, the emergency department, they're doing lumbar punctures on patients, right? We have the ME panel available late 2015, early 2016. What better way of, one, working out an operational workflow, offering this one panel up front, but also looking at the clinical impact that this multiplex PCR panel, the BioFire ME panel, would allow. So as you all are very familiar with, here is the meningitis encephalitis panel. As you can see, all the bacteria, viruses, and yeast that are available on this. So imagine, here we are telling the emergency room physicians, listen, you do the LP, send the specimen downstairs to the lab, and in a short period of time, we're going to be able to tell you whether these pathogens are found in the specimen, right? And again, we have the list of bacteria there, the viruses, and the yeast, and to be able to tell them that. And they kind of looked at us and said, really? We're really going to be able to do this right here. This isn't a send out. I'm not going to be sitting around waiting for a week or two to get the answer. No, we're going to be able to give you this information right up front. So here's what we did, right? The common theme that you're hearing from today's conversation is that this is a joint effort between clinical services and laboratory. And here Arpad said from day one, right, he has always been engaging his clinicians and asking them, does this work for you all? What do you all need, right? I just need to digress a little bit. Coming from larger medical centers, I hardly ever knew what the laboratory was doing. There was never that connection between, oh, the laboratory has this new test, maybe we should utilize it, right? Yes, I understand we all get emails, we all get newsletters, but I'll be the first one to admit, don't necessarily read them as much as I should. So there was that connection really didn't feel all that strong. Here at Howard Hospital, that connection is really strong. I know that I pick up the phone and I call RPAD, I call my microbiologist, they call me, we have an ongoing conversation. So we said, how are we going to bring this incredible new technology, this multiplex PCR, the BioFire ME panel, how are we going to bring it online? How are people going to know that it's there? How are they going to use it and obviously use it effectively and appropriately? And how do we get the information back to them? So what we sat down and we did was we developed an implementation plan, right? Arpad and his crew were going to set up the BioFire. They were going to run all the tests that they need to run. They're going to bring it online, right? And we're going to set up a go live date. What we did in anticipation of that go live date is that I led an educational effort with the clinical staff at Howard Hospital, right? I met with the emergency department physicians, I met with hospitalists, with the advanced clinical practitioners that we have there, the intensivists, explaining to them what the ME panel is, explaining to them the technology, explaining to them how we're going to use this. And one of the great advantages of the ME panel is we were able to paint a picture right away of the patient you need to use it on. What we decided is, listen, you do a lumbar puncture, you need to send that specimen for BioFire, right? Let's make it really, really simple. Okay. I also showed them the results because I think it's really important for them to be able to see exactly what they're going to see on their screen, right? And you can't get much more simple than this: not detected and detected, right? I mean, rather straightforward. It doesn't take, so simple, even an infectious disease physician can interpret this, right? And then what we did was we launched the panel, right? And then we came back about a month or so later, and we looked at the 2025 cases that we had. We looked to see what diagnosis or was there a pathogen identified. We looked to see what the clinical impact was, and we presented this data to the medical team again and said, okay, great, we launched the ME panel, right? Now let's take a look at what the first group of cases were. How did this impact? Hear back from the clinicians, right? And RPAD was there to hear what they thought. Also, if there was any adjustments with regards to the workflow, and also to answer any questions they have and re-educate. Now, one of the things that I left out is that because BioFire is so important from a pathogen identification standpoint, what we did was we not only brought this part of the clinical infectious diseases service, but we actually brought this on board part of the antimicrobial stewardship program. Right, and I think especially as we go through the clinical case in just a little bit, you'll see why it's so important and so relevant to bring BioFire and rapid diagnostics part of the antimicrobial stewardship program, because it really does impact that quite a bit. Okay, so we also said why, also explain to them what is the difference that having BioFire makes, okay? Because remember, before BioFire, right, the conversation is the emergency room doctor calls me and goes, hey, I think I have someone with meningitis. What test do you want me to order? Okay, and we have this conversation of, well, I think we should order this, I think we should order that, and then I'm hoping they're going to order all these tests, right? So the idea of having this rapid diagnostics and being able to have pathogen identification allows us, number one, to have improved patient care. And as Arpad has said, that is the key and the number one reason everything that we do, right? We can also optimize treatment. Right? We know we're going to get reliable results. You saw the sensitivity and specificity in the previous slide, right? And we can reduce the overuse of antibacterials. And, you can't underestimate the patient satisfaction. To be able to say, hey, we did the lumbar puncture, and within 2 hours, we're able to tell you I identified a pathogen. That has a tremendous amount of impact for the patient. And also, one of the things that we've seen is that it also further develops that community belief in our medical center, right? Despite the fact we're in a small town, the community has full confidence that coming to Howard Hospital is the right thing to do. I know I'm going to get state-of-the-art care there. Okay, so here is the algorithm, right? A rather complex algorithm, and I do apologize that the arrows got a little bit offline there. Here is the complex algorithm that we developed. Patient comes into the emergency room. You think they have meningitis, you get a lumbar puncture that goes straight to BioFire, and then we do pathogen identification. We kept it really simple, right? But we also said, listen, you do an LP, it's going through the ME panel with BioFire, right? That was a straightforward algorithm that we set up. Now, what did that algorithm do? Well, that algorithm completely changed the conversation that I have with an emergency room physician or with a hospitalist, right? They're not calling me as an infectious disease physician and going, okay, what are the tests you want me to order? What should we do here? What do you want me to start, right? The conversation we have is, hey, Dr. Siddiqui, we just did an LP. BioFire came back showing strep pneumo. We're moving, here's what I was thinking. What do you think? What should we do, right? Completely changes the conversation that we have regarding that patient. Also targeted therapy, right? By having the meningitis encephalitis panel, we are either reducing unnecessary exposure to antibacterials. It's, someone over 55 who has strep pneumo, well, they don't need to get listeria coverage, right? Secondarily, we unnecessarily exposure to antivirals. We know it's a bacteria, right? Or the construct. We know it's a virus. They don't need to be exposed to antibacterials. That is completely within the ethos of our antimicrobial stewardship program. Also has an impact on infection prevention, right? Those pathogens that we know we need to isolate patients on right away, we're able to make that decision right away rather than isolating every single patient that we have with meningitis, right? So again, I can't stress enough, it's about a team effort. It's about the laboratory and everything that Arpad and his team does, working with the clinical services, and in this case, specifically it's spearheaded by the infectious disease service, but we're working with our hospitalists, we're intensivists, every clinical care provider there, and we have with this technology that BioFire brings on board, that all three of these cogs working together, that's what gets us to the success that we have. Okay, so let's change directions again. So Arpad, I want to ask you now, right? So this is a question that I hear all the time. Tell me, how does the size of a hospital impact your decision to bring BioFire into the laboratory?
It is, well, totally irrelevant. The size of the hospital, if from my point of view, the smaller we are, the more we need it, the more we can't afford not to have it. By the way, in terms of, I want to make a comment about the team effort and the success that you mentioned earlier. I totally, wholeheartsurely agree. It has done wonders for our team spirit interdepartmentally, ER, ICU, Med-Surg, the laboratory. With the high fives that go around on a success and a save are unbelievable. It does wonders for the sense of purpose and value that we bring to our community. I'm just totally jazzed about that. I couldn't let that one pass. Because it's all about patients, and the stories and the stories there are absolutely fantastic, and I know you're going to share some with us. So the makings of a high-performance small hospital laboratory utilizing lean principles. So what we decided is, again, it all comes from survival. We have to do more with less. And certainly BioFire does huge amounts with minimal effort as far as the laboratory is concerned. And it has tremendous benefits for the patients who need it the most. So it values, we believe in adding value through the elimination of waste, service, productivity, quality. We feel that this really makes our sense of purpose in the laboratory huge. We have some of the highest employee satisfaction surveys that we've ever had inside the laboratory. Of course, our patients, there are many, many stories of the saves that we've had, both I've only seen one Cryptococcus in my life. I have not seen very many Cryptococcuses in the laboratory, but we had one. We saved a very young patient who was 8 months old and had a lumbar puncture, and she, instead of losing limbs, very to little damage, and we saved her. We're able to get her on therapy very quickly. And of course, there's the geriatrics. A little old lady comes into the hospital. The doctor looks over at the family and says, "So we have a little bit of dementia going on here." And of course, the family members are shaking their heads. No, not at all. Instantaneously lumbar puncture, and what do we get? Haemophilus influenza. We saved that lady's life. So in terms of all these things, so the physicians appreciate what we do for them, of course, and then the patients, they really appreciate knowing that it is or isn't what it is.
So Arpad, let me go back to the key point you said, right? I asked you, how does the size of a hospital impact it? And you said it doesn't impact it. Let's go back to that again, because I often hear, right, when I'm working in other critical access hospitals, small community hospitals, that, oh, no, this is way too advanced. We don't need this sort of stuff. And tell me from a lab director standpoint, why a lab director would think that, and why you think that's not, you don't think the same way?
I don't think the same way. I believe that it is way advanced, but I believe it's really, really simple. You're talking less than 5 minutes of hands-on time to do this kind of benefits. It's unheard of in the past. You would have to do things for hours. It would take you a day to do these type of things in the past. The technology is black box technology. It's super simple. I'll end it there.
And it hasn't required that you hire more personnel, has it, into your laboratory in order to bring BioFire on board?
No, absolutely not. We do more with less.
Right. Well, thank you. So with that said, let me turn it back to Candace, and we have another polling question. Candace, please help us.
Thank you, Dr. Siddiqui. Audience members, we do have another poll question launching on your screens right now, and we would really appreciate if you would participate in it. That poll question is, what currently limits you from using the ME panel? Audience members, you may select from the following options: the size of your hospital, the types of patients you serve, budgetary issues, lack of clinical services indicating a need or desire. Audience members, once again, we have another polling question appearing on your screen right now, and you may vote on the option that is most relevant to you. That poll question, once more, is what currently limits you from using the ME panel? You may select from the size of your hospital, the types of patients you serve, budgetary issues, or lack of clinical services indicating a need or desire. Audience members, please get your votes in right now before I close the poll shortly. Now it looks like a majority of our audience members have voted. I'm going to close the poll and share the results with you now. Now it appears the most popular answer is budgetary issues at 73%, followed by lack of clinical services indicating a need or desire at 23%, followed by the types of patients you serve at 4%, and no votes for the size of your hospital. Thank you very much, audience members, for participating in this poll. Dr. Siddiqui, back over to you.
Great. So Arpad, let's take that information from the polling question and move on. So tell me, what is the talk about how the budgetary issue affects you, how you were able to make this decision, please.
Well, in terms of bringing in the system itself, it was not that big of a budgetary issue in the sense that the payback on it was, the return on investment was huge when it comes to that. The cost of running the test itself is relatively expensive to say compared to running a cholesterol or something like that, or some other, or even running a cepheid, it is. But again, the payback, it's on the back end that you are really addressing those budgetary concerns and winning. You know, like I say, a lot of people say, we can't afford to do this. My response to that is very simple. You can't afford not to.
So let's expand on that. So tell me, how was it a hard sell with your administration to convince them that, hey, we need to bring this technology in, we need to do this from a budgetary standpoint?
No.
All right. That's straightforward. No pushback from them regarding that.
No.
That's great. That's great. Well, let me, if you don't mind, let me take a stab at lack of clinical services indicating a need or desire. I think it's because, it's one of those things, you build it and it will come. Have you, the respondents who asked for that, let me ask you, all right, have you asked your clinical services whether they actually want this? Because remember, a lot of our physicians, they don't know that this is out there or they have access to it, right? So if you go to your emergency department physician and say, hey, listen, we have the ability to bring on the Meningitis Encephalitis panel from BioFire. Would you utilize this clinical service? As a physician, I find it extraordinary that the response would be, oh, no, thanks. I would much rather you package all this stuff, you play FedEx, send everything off to a reference lab, let me keep the patient in the hospital on a whole bunch of medications for a couple of weeks, and then we'll get an answer, right? I mean, I just don't know that a physician practitioner would say that. So my response to those who said lack of clinical services indicating a need or desire, I don't think you've had that conversation with them. And if you had, please let's discuss this in the Q&A, which is coming up shortly.
Dr. Siddiqui?
Please.
Dr. Siddiqui?
Yes.
As a matter of fact, at Howard, we found this is exactly what drives improvement here. That's true. I go to one of my execs and I could present the argument, but if I go to one of my execs and I say, Dr. So-and-so feels this is a very strong argument for that, or if Dr. So-and-so also goes to the exec and says, hey, we really need this, it becomes a moot point at that point. So the communication to the clinicians is huge.
I couldn't agree with you more, and you've done a fabulous job with regards to that. So let's take everything we've talked about and let's talk about a case. Now, this is a real case. There's no fictitious. This is absolutely a patient care that I was involved in, okay? So you've got a 42-year-old gentleman, no past medical history, right? Not taken any medication before this incident, right? Shows up at the emergency room, says, I've been feeling progressively poor the last 3 days. My headache is getting worse. I feel ill. No one else at home is sick. This is what I have. I'm taking ibuprofen, but it's not helping. I'm trying to hydrate. I just don't feel good. Okay. So what happened is the emergency room department physician said, headache, slight fever. Let's do a lumbar puncture. Did a lumbar puncture. Here you see what the CSF showed, and more importantly, this is the patient with the CSF fluid went right down to ARPAD's lab, ran a BioFire, and it came back human herpes virus 6, right? Yep, human herpes virus 6. So for those clinicians in the group, no, this person's not immunocompromised. There's no reason why this person should be a risk factor for HHV6, right? And again, we got this, and the call that I had and the conversation that I had with the emergency room physician was, hey, Dr. Siddiqui, got this gentleman. We tapped him. BioFire came back HHV6. What do you want to do? And it was like, that's the conversation we had. So we started acyclovir right away. What happened? The next day I rounded on the patient. This was probably about 7, 8 o'clock at night. The next day I rounded on the patient, and he's like, hey, I feel great. Can I go home? I'm like, well, hold on a second here. You just came in barely 12 hours ago, and you're telling me you feel so much better? He goes, yep, they started the medication. I can't tell you. First time I slept well, much better sleep than I had a few days ago, and I'm feeling good. So this is what I talk about, the whole change in conversation, because without having the ME panel there, okay, here's the conversation we would have had. Well, this guy came in, clearly he's got white blood cells in his CSF. We started Vanco, ceftriaxone. We're going to start acyclovir. We're going to send this to a reference lab, and we'll have a daily conversation, and we'll wait for 5 to 7 days for the reference lab to identify something, and we'll go from there, right? That's the change in conversation by having the BioFire ME panel available on site at Howard Hospital, right? So for this case, it helped in targeted therapy, right? Reduce the length of stay for this patient because, matter of fact, within 72 hours, this patient is out of the hospital, right? At home with home health getting his IVA cyclovir and completing therapy, right? It limited him, it prevented him from being exposed to unnecessary anti-infectives. It definitely made an impact on pharmacy costs because we weren't doing vancomycin trough levels, we weren't giving him vancomycin, we weren't giving him ceftriaxone. It reduced lab costs because we didn't send off for 4 or 5 different tests. We didn't send it to a reference lab. Patient satisfaction, I mean, he was elated. We were, the ED physician was able to tell him, hey, we found this pathogen. Pathogen fits the clinical scenario that you have, and obviously definitely resulted in improved patient care. This was not a patient who got transferred out of our facility. This is a patient who we had to call someone else to deal with. We were able to take care of this patient right here at Howard Hospital and get everything done. All right. So with that said, I really want to thank you all for engaging in this conversation. This has been a wonderful opportunity for RPAD and myself. My information is there in case you want to, if you have, you want to reach out after this conversation. But more importantly, we now want to switch over to any questions that you may have. So Candace, I'll hand it back over to you, and RPAD and I are available to answer any questions.
Perfect. Thank you very much for that wonderful presentation. Audience members, at this time, I encourage you to continue submitting your questions or comments right now using the questions window for the Q&A portion of this webinar. Now, I've already received some questions, so I'll start with those. The first question here is, how have the changes in reimbursement affected your pricing or billing strategies?
RPAD, do you mind taking that one?
Sure. There are certain mitigating coding solutions that we can use, and yes, they do affect, but frankly, there is enough margin there to where that's really not an issue. Actually, I kind of look at it as a bit of a benefit to the patient in the sense that the prices, for them can possibly go down. There's well enough margin in doing this test to make it very profitable and to have a very positive impact on laboratory revenue, as a matter of fact. So that's it.
Perfect. Thank you very much, RPAD. Another question in similar vein, Medicare is beginning to investigate the high cost of multiplex PCR testing and considering limiting reimbursement. How is your hospital planning on dealing with decreased reimbursements when the cost of the individual tests is so high?
RPAD, I can take it from the clinical standpoint, but why don't you take it from, offer your perspective?
I kind of feel the same way that I answered it just a little earlier. There's enough margin there to take care of this. I don't believe that that's going to be an issue. Medicare does this as a part of their regular practices, and that's just fine.
And for me is I welcome the fact that CMS is taking a look at it, because look at the case that we had. We ran routine CSF, found that they had an elevated WBC, ran BioFire, and got an answer. I mean, we didn't do an extraordinary number of tests. We did the most appropriate tests. And I think that's what's being missed in this whole CMS talk, is that we're not running 15 different tests hoping to find, we're running multiplex PCR on a patient who had meningitis, and we got an answer. So I think if nothing else, this will further support the fact that CMS needs to continue to reimburse for these services, because these are the results that we get from this actually don't necessitate us doing further testing. This gives us the answer. So this actually, I'll actually argue the point, this actually reduces some of the additional cost of care.
Perfect. Thank you for sharing both of your insights on that issue. Audience members, once again, I do encourage you to continue submitting your questions or comments right now during the Q&A session of this presentation. The next question we have here is, do you have CSF criteria that would prevent you from loading a CSF sample on your BioFire? For example, if the WBC count is less than 3 normal glucose protein levels.
Of course, I'll take that. Yes, the patient has to have signs of meningitis, right? I mean, we do occasionally have patients who come in for an LP for hydrocephalus, get a large volume tap, or we have patients who come in for an LP in order to get chemotherapy. Obviously, we're not going to run that through our BioFire system. So, yes, that's part of the education with the providers. Listen, we need to have concern for meningitis before we're doing this. And if I didn't say that before, that was my mistake. I apologize. But yes, we do have those criteria in place.
Thank you very much for that response. Our next question here is, what was the biggest challenge you encountered when bringing on this test?
Arpad, I'll let you take that one.
You know, I think education, and when we had Dr. Siddiqui come in, so when you bring the test on, and some of the physicians may not have had the exposure to the educational opportunities that were provided, they were behind the eight ball. So we had Dr. Siddiqui come back twice, and maybe even more. Whenever we got a new panel on, we'd have him come back and speak at our physician educational meetings, which happen about once a week on Fridays. So we'd pick an appropriate Friday, and he'd come in and speak about the new panel, the new PCR. He could review questions about the old PCR. And by the way, physicians will ask on a constant basis. They will ask some new facet as to something that they encounter and what to do with the test at that particular point. They may not have had the chance to talk to Siddiqui at that particular point, but that is an opportunity. So I'd say one of the challenges we faced was education and getting that done through all the staff completely.
Absolutely, and I really don't think it was a challenge. I mean, I got to tell you, the moment, when I toured the laboratory and I saw those boxes sitting there, there was no hesitation. I went, oh my gosh, yes, let's go. I mean, it was enthusiasm. And then, I don't ever mind anyone calling me and asking me, hey, what's the right test to do here? Should we do this test here? I never mind that. Matter of fact, I really appreciate that. So we really are very proactive, as Arpad said, in talking about this. And I think now, really, because of this joint effort between the laboratory and clinical services, right, BioFire is really within the culture of Howard Hospital, right? There's not a question. We're not reminding clinicians that they need to do this. I mean, we now have clinicians educating other clinicians, right? When someone new comes into the ED, right, and they do an LP, right, the ED physicians, the nurses are like, I'm taking this down, we're sending that for BioFire. And if there's a new physician, they're like, huh? Like, oh, no, we've got BioFire here. All of our CSF, we're concerned this patient has meningitis, well, it'll run through BioFire. You'll get an answer within an hour or two. And really, we're not having to do that basic education anymore. But anytime someone has a question about the ME panel, one of the other panels that we run, we're always happy to answer it.
I really think we'd have a revolt in ED if we were to run out of test kits, let alone lose the test. The other interesting thing was during one of the emergencies that we had, I think it was a fire emergency that we had a year or two ago. There was an outbreak of norovirus in one of the shelters. Guess who found the test? We did. We found the norovirus right here.
Absolutely. I agree with you, the revolt.
Huge benefit. And do it quickly.
100%.
Thank you very much for that response there. The next question we have here is, do you perform supplementary or reflex Cryptococcus antigen testing in conjunction with the ME panel?
Well, if someone is found to have cryptococcal meningitis, of course I want a cryptococcal titer. So yes, but the fact that we were able to identify that pathogen is tremendously important. And then obviously, as an infectious disease physician, I'm involved answering the questions about what type of immunodeficiency, or does the patient have the immunodeficiency. Yes, we will absolutely get a serum cryptococcal antigen as well, so we get a titer on them as well as a CSF titer for those clinical services. But again, the fact that we are able to recognize Cryptococcus is just the ability to do that so quickly really helps our diagnostic capabilities tremendously.
Perfect.
Arpad,
Thank you for.
Anything you want to add on that one? Sorry. Arpad, anything you want to add on that one?
In terms of reflex testing, no, but I just have to keep commenting, with Cryptococcus, we don't see it much, and it's a much safer way to handle the specimen in the laboratory, so to find Cryptococcus that way, yeah, absolutely.
Perfect. The next question I have here is, I am thinking more of the value of ruling in and or ruling out. Can you discuss your experience with the negative predictive value of the ME panel? What happens when the panel is negative, and how does it fit into other lab results?
Absolutely. I mean, one of the things you have to recognize is, Candace, what's the best way for me to go back to the slide that has the pathogens on the ME panel? Do you want me to toddle back, or can you toddle back and put that slide up? Would that be possible? There we go. That's the one. Thank you. One of the things that we'll always remind people is that, listen, these are the pathogens on the ME panel, right? And these are the most common pathogens that we encounter, right? So if the ME panel is negative, it doesn't mean that the patient doesn't have meningitis. That's one of the key education points that we stress, right? Here are the most common pathogens. If the ME panel is negative and doesn't identify these pathogens, that's all it's saying. It doesn't identify these pathogens, right? So we have to now look for other pathogens and manage this patient appropriately in that sense. The key issue is that you have someone who has a clinical symptomatology of meningitis. You clearly have white blood cells on the CSF. You feel this patient clinically has meningitis. The BioFire panel pathogen identification is negative. All we can say is it's not these pathogens. It must be something else, and we have to look elsewhere. And I really want to stress that very significantly. A negative panel doesn't mean they don't have meningitis. As far as the sensitivity and specificity, we haven't found a situation where this hasn't given us appropriate answers, and we haven't, at least in my years of working with the ME panel, a situation has never occurred where the patient ME panel was negative for strep pneumo, but then their blood came back positive for strep pneumo. Well, we haven't seen that. We haven't seen that occur. So the specificity is absolutely held true for us, as indicated here.
Thank you very much. Now our next question is, who is currently your biggest champion of this new technology at Howard?
Arpad, who do you think it is?
Well, it would definitely be our emergency room staff. Oddly enough, our chief of orthopedics here stopped me, not more, you don't know about this, Dr. Siddiqui, but he just stopped me 30 minutes before we started this, 35 minutes before we started this webinar. And he is interested in some of the newest developments that BioFire is got coming down the road in terms of some of the joint fluid that may be possible to do. And so he's very, very interested in that, and has asked me to talk to you about that as well. So to see what the possibilities here would be. For us, it's definitely the emergency room and our orthopods. They're very, very in tune with that.
I'm a little disappointed you didn't say it was me, Arpad, but we'll talk about that later.
No, that's very true. By the way, that's very true. You're absolutely right. You are truly a champion that way. Very much. Yeah.
No, it's a team effort. But and I really think it comes back to the fact that you have different physicians coming and talking to you. That, I think, again, is one of the biggest take-home messages I hope that we can convey during this conversation today, is that the importance of clinical laboratory and clinical providers talking. There's this great divide there, and I don't know why it's been there. I've experienced that throughout my career. That's why the fact that I have such a great rapport with Arpad, the fact that he has no hesitation in calling orthopedic surgeons, calling any clinician at the hospital and going, hey, tell me how this test would be used. Tell me, is this something that you want? That's the kind of culture that we need more of. We got to get out of this siloed mentality that we have in healthcare. Siloed mentality doesn't work, and especially not in healthcare. We've got to get out of it.
It's harder in the bigger hospital that you're in. I think it's harder. I think in a small hospital, it's probably a lot easier. But just to piggyback on that as well, The particular physician that I'm referencing earlier with you, Dr. Siddiqui, in that particular case, this man is very busy. He has very little time. And for him to stop a moment and ask me to speak to him about opportunities moving forward is an unbelievable testimony as to how important it is to him.
Absolutely, couldn't agree more. Candace?
Thank you very much. Our next question here is, what does the dialogue with your physicians look like when reporting the results to them? Do you find yourself interpreting the results for them often?
No.
Pat, why don't you take that? Yeah, and I'll tell you my view.
Don't. I think if we have any questions, and they're typically questions, when things are negative. That's an example. When things are positive, they already call Dr. Siddiqui. But when things are negative, that we basically have to explain that it doesn't cover. There may be something that targets don't cover, and so in that particular case, we'll also refer them to Dr. Siddiqui. Very, very easy that way. I don't find a lot of questions coming our way that are very difficult. They're very easy reference things. We don't typically answer complicated questions related to clinical things at all. It's basically we just refer them.
Yeah, and for me, if there's any questions regarding a test result, they'll the clinical providers will call me. It was really funny. Well, when that happened with one of the panels, when I go back to, if that happens with one of the panels, I should say, whenever I go back from an education standpoint, I'll make a note to myself and make sure that we cover that. It happens incredibly infrequently. It usually happens when we get new physicians coming on to the staff. But I think you can't get easier to use than detected and not detected, right? You really can't. The questions that I probably get most from the emergency room, not necessarily with the ME panels, with some of the other panels, hey, this came back positive, what should I do? And I think it's a very appropriate question, and that's what I say, the BioFire completely changes the conversations that I have with the emergency room with providers.
Perfect. We have time for one last question here. Have you had any issues with contamination of the samples, and if so, how did you handle it?
Arpad?
Nothing in this world is perfect. And oddly enough, typically you're going to find what's in the sample. So we generally have not had any, with the CSF, we have not had anything that were false positive that I know of, at least. It's very, very straightforward that way, and it's not. But it certainly is a possibility. I mean, if there's a little bit of genetic material there, it will find it.
Arpad, I work the 4 hospitals that have BioFire ME panel. Yes, nothing's perfect, but honestly, I can't think of a single instance where we've had something come up and it didn't fit clinically. I honestly didn't, and that's not because we're just here presenting. It just hasn't occurred. It just hasn't.
I agree. There's nothing in my mind that I can recall.
All right, well, thank you both for answering those questions. We've now reached the end of the question and answer portion of this webinar. If we were unable to attend to your questions during the Q&A, please refer to the contact information appearing on your screen. At this time, I'd like to thank everyone for participating in today's conference. You will be receiving a follow-up email from XTalks with access to the recorded archive of this event. A survey window will be popping up on your screen. Your participation is appreciated as it will help us to improve our webinars. Now please join us in thanking our speakers, Dr. Javed Siddiqui and Arpad Peter, and feel free to share the recorded version of this webinar when it becomes available using the link in the chat box. We hope you found this conference informative. Have a great day, everyone.